Hi, good afternoon, all. Am I audible?
Yes, ma'am. Good afternoon, ma'am.
Okay, so today we are going to talk about
Yes,
respiratory
ma'am.
symptoms.
Good afternoon,
We have
ma'am.
our faculty here, and first of all, I would like to welcome you all for the session. And I'm hand over to Anusha ma'am to introduce our faculty. Ma'am, over to you.
Hi, good afternoon, everyone. This is Anusha. Today I'm your facilitator. Today our session is respiratory symptoms. So our speaker, Ms. Dr. Susan John, she's a compassionate clinician with career rooted in diverse medical excellence, and she had a 1 year experience in gastrosurgery department and 2 years of dual experience OBG and gastrosurgery and 6 months of acute care experience in the emergency department at Astar Hospital, Dubai, and 1.5 years at Palliative, India, focusing on a palliative care and holistic patient support. Successfully completed her CCPM course also. Welcome, ma'am. Welcome for this session.
Thank you, ma'am. Hannah, please make me as a co-host, then I can share my slides.
Yes, ma'am.
Okay.
Start. Okay. Okay. Continue.
So I will share my slide. Is it visible?
Yes, ma'am.
Yes. Okay. So, good evening, all. Today we are dealing with the topic respiratory symptom management in palliative care. It is a little bit different from our normal setting for the management of respiratory symptoms. So, it's very important. You have to study these topics, that is breathlessness and cough. These are the most common respiratory symptoms we are dealing in our palliative care patients. So, first thing is breathlessness. So, what is the prevalence of this breathlessness in palliative care patients? The first thing is lung cancer. The 75% of lung cancer patients have symptoms of breathlessness. Next thing is COPD. That is a progressive disorder, and most of the time the patient has severe breathlessness during the end of disease. And next thing is pneumonia, interstitial lung disease, pneumothorax, emphysema, pulmonary embolism, advanced cancer with metastasis, heart failure patients, renal disease patients. So these are the some conditions which the patients can come with the breathlessness. So what are the things usually we are focusing when the patient has cancer and with symptoms of breathlessness? So usually if the patient has cancer with symptoms of breathlessness, the mechanism is most of the time the obstruction of the airway. The tumor cells, they will obstruct the airways. Sometimes cancer related pleural effusion, that fluid is filled in the pleural cavity. Replacement of lung by cancer, those are large mass or large tumors which will replace the lung tissues. Lymphangitis carcinomatosis, cancer microembolism, small emboli which will occupy the lung vessels. Pericardial effusion, that is similar to pleural effusion. There is something called pericardium around the heart. So the fluid filled within the pericardium, then it is known as pericardial effusion. Then cardiac metastasis. The primary is something away from the heart or lung. So some metastasis, the advancement to the heart or maybe to the lung. So these are the main causes for the breathlessness when the patient is presenting with cancer. So what are the cardiac causes? There are some non-cancer causes for the breathlessness. That is cardiac. That is cardiac failure patients, patients with angina, arrhythmias, myocardial infarction. So these are the some non-cancer causes for breathlessness. Other important thing is anxiety. So anxiety also has a specific role in the symptom of breathlessness. So ascites, sometimes that is ascites. The patient has symptoms of abdominal distension, cachexia. So cachexia patients' respiratory muscles become more and more weak, and superior venous cavity obstruction, chemo-induced fibrosis and pneumonitis. That is post-chemo radiation-induced fibrosis and pneumonitis. So these are the conditions where the patient may present you with breathlessness. So while discussing with the definition, what is breathlessness? So it is a subjective experience of breathing discomfort. So it is a subjective experience. It is not as similar for me or you. It is different from each one. So it is a subjective experience and it is very distressing symptoms. It is very distressing symptom for patient, caregiver, and also doctors. Why for the patient? It is very difficult to uh, what the patient has air hunger, not able to take enough breath. So the patient is in severe distress. So it is very distress to seeing our loved one or our family members who are suffering with breathlessness. That is a caregiver distress. And why it is distress to doctors? So it is very difficult to manage when it is come with advanced malignancies or maybe advanced disease like COPD. So that time the symptom management is very difficult. So that is why we are not telling that it is very distressing to both patient, caregivers, and also to doctor. So the main thing is the underlying etiology is progressive. So we already discussed most of the causes, that is maybe due to lung cancer, maybe due to cardiac causes, maybe due to effusions, pericardial effusions, airway obstruction. So COPD patients, pneumonia patients, interstitial lung disease patients. So here the most of the time the underlying etiology is progressive. There is no particular curative treatment is possible. So that time this breathlessness, the severity and intensity of the breathlessness also increasing with the disease progression. So usually we are more focusing to the not we are means the healthcare professionals, they are more focusing to the physical symptoms. But as a palliative care physician or palliative care nurse, you also we are also focusing apart from the physical symptoms, we are also addressing the psychological problems, emotional things, spiritual aspects of the symptoms. So usually the real issues they are facing, the patients with breathlessness they are facing is frustrations, anger, depression. Why the patient is more frustrated? The patient is not able to go for any job, not able to go for any social functions, not able to do their ADLS independently. So this will cause frustrations, anger, and sometimes depressions. And then that these symptoms can result in limiting the activities of their daily living. This completely depends on the family. The patient need support for everything, that is for bathing, for washroom, or for what wearing clothes or having food. So the patient is completely depending to the family, and there is loss of role in the family. So when the patient is become bedbound or not able to take enough decision, the patient has lost their role in the family, and there is social isolation, not able to attend any social functions. So nobody is coming to their home to see him, and no social engagement for the patient. So that will result in social isolation. So these are the real issues they are facing rather than the physical symptoms. And large psychosocial and emotional burden. The patient has feeling that because of this emotional burden, and also due to they are treating the disease for the long term. So it will cause psychosocial issues or financial issues. When the patients with respiratory conditions undergo a social death than before a physical one. So this is very, very important. You have to address these real issues for the patients, and anxiety and fear of this. So each aggravation of symptoms or each time of the active symptoms, the patient has increased anxiety, fear of death. So these are also the real issues they are facing. Usually, while we are asking about the symptoms, if you are assessing the breathlessness, usually our questions is like that. That is, have your breathlessness reduced? Then they will get yes or no answers. If the patient says yes, patient has better relief. No, not get any better. But here the conversation will stop. So this is the usual questions we are asking, but this is not the right way to ask assessment for the breathlessness. So, how we can modify the questions? So, usually the patients they will describe the symptoms like sometimes they will tell that, doctor, I am not able to take enough breath. My breath is don't satisfy me. I have to take more effort for a good breath. There is a feeling of chest tightness, air hunger. I have unsatisfied breath or inspiration. So these are the different things. Usually they are telling you that is a subjective experience, what they feel while they have active symptoms of breathlessness. How we can modify our history taking? So you ask the patient, what have you given up for avoiding breathlessness? Are you coping the symptom? Are you acknowledging them? So these are the different way of assessing the history taking or assessment of the breathlessness. This will yield more different answers. What are the real issues they are facing rather than physical symptom? They are also facing some psychological or emotional or psychosocial issues or other religious issues, spiritual issues. So that you can yield different answers from these type of questions. So you have to modify your history taking. So this is the breathing, thinking, and function vicious scale. So here the breathlessness, when the patient has symptoms of breathlessness, the thinking, that is the thought about that some dying or gasping for breath, these memories of past experiences will increase the anxiety and distress, feeling of panic. So these will again increases the breathlessness. So when the patient is coming with breathlessness, patient has thinking that the patient has fear of death, past memories of these similar episodes, gasping for breath. So these thoughts will increase the anxiety, distress, and that itself increases breathlessness. That is one cycle. Another thing, when the patient has symptoms of breathlessness, the patient become more less active. The most of the time they are bed bound because small exertion or small movement will increase the breathlessness. So they become more bed bound or more wheelchair bound. So the activities become more and more less and they become more getting isolated. So they need help with the others for their daily activities. So this will result in muscles involvement in moving and breathing become less fit. That is, there is high chance of muscle weakness or wastings, cachexia look. So this decreased function will result in muscle weakness and that itself increases breathlessness. So this is the second cycle. The third cycle is breathing. When the patient has becomes breathlessness, breathing in the upper chest or the small breaths or air trapping in the lungs, that will result in the patient become more and more harder to work to get a good breath. So that itself increases the breathlessness. So these are the vicious cycle that relate to breathlessness, thinking, functioning, and breathing. So this is very important. So this you have to study. Any doubts till now? If you have any doubts, you can ask. You can use the chat box, otherwise you can unmute and ask the question. Any doubts?
Dear participants, kindly ask your doubts.
No, ma'am.
No doubts. Okay, then we can proceed. So, how we can take the history? Usually,
And there is one doubt, why
yes.
this anxiety will happen?
What is the question?
Why this anxiety will happen?
So, why this anxiety means when the patient is not able to take a good breath, the patient has a fear of death. That itself increases the anxiety. When we have a fear of death, the patient, our anxiety is also increased. We cannot able to do anything as properly or as good, we have increased the anxiety. So the fear of death is very much increased the anxiety. Am I right? This is a panic situation. He is not able to take a good breath. If anybody with the similar symptom or they are who are suffering with breathlessness or some other respiratory symptoms, they know clearly. how distressing this breathlessness? Srijana?
Yes, ma'am.
Okay, so the fear of death, yeah, that will increases the anxiety.
Okay, thank you, ma'am.
So, how we can take the history as similar to our pain? We can take how is the onset? What are the palliative factors? What is the quality? How it is related to other symptoms? What is the severity and what is the treatment? That is how onset. When did it begins? When this breathlessness begin? What is the duration? How long she or he has the breathlessness? How frequent does it occur? What is the frequency of this episode? Sometimes once in 3 months, or once in a month, or once in 2 weeks. So that is the frequency. What is the palliative factors? What makes it better or worse? Maybe some treatments, maybe some inhalers, antibiotics, injections. So what makes it better or worse? Maybe it is worsening during the rainy season, the climate, maybe the cold. So what are the things which make it better or worse? What is the quality? Quality means here is how he or she describe it. Initially, we already told that how it is they describe. Maybe air hunger, unsatisfied breath, chest tightness, how he or she describe it. That is the quality. What are the related symptoms? Any related symptoms like cough, isolation, anxiety, like symptoms. Severity. Severity, we can assess it from 0 to 10, like pain. Now it is on also that you so physical examination. For every system, usually we are doing vital examinations, respiratory rate, how saturation, pulse oximetry, peripheries due to hypoxia. So that is look for any hypoxia symptoms like cyanosis, systemic examination, so inspection of the chest. Is the patient is cachexia? Is the patient is using any respiratory accessory respiratory muscles for the breathing? And position of the patient. Usually, sometimes the patient is more comfortable in the propped up positions or leaning forward position, and pursed lip breathing. And is the patient is using any active accessory muscles? Nasal flaring is there or not? Mouth breathing is there or not? So these are the physical symptoms you can identify from the patient while they are having active breathlessness. So investigations. Usually, in an emergency department or in our hospitals, if the patient is coming with breathlessness, usually we are rushly doing some of the blood investigations like CBC or other blood investigations, ABG. So many blood investigations usually we are giving, and chest X-ray, CT. So so many investigations usually we are doing. But in palliative care settings, uh, usually we are going to do an investigation. Before advice to do an investigation, you think twice, because if the patient is going to alter, if it is going to alter the line of management, then we can do the investigations. Otherwise, it is not benefit to the patient, and it will cause more financial burden to the family also. Because palliative care patients, most of the time, the cause is for the breathlessness is maybe due to cancer. That is not a or this is not a curative thing. The disease progression is the underlying etiology is progressive, like COPD or interstitial ILD patients. So these things are the underlying etiology is progressive. So the complete curative treatment is not possible. So during the end stage of disease progression, most of the time the patients didn't get any benefit from these investigations. So if you are thinking to do an investigation in palliative care for the breathlessness, you should
जिस
think
किनारे
twice.
से मतलब वो उसके पेट में घुस जाएगी
Sarita, any doubt?
हाँ वो नहीं
Okay.
Ma'am, you can
So,
continue.
okay. So, not very useful in assessing chronic breathlessness due to advanced disease. Expect to exclude some treatable problems such as pleural effusion. we can give. If any correctable cause is there for the breathlessness, we can proceed with the investigations to correct it. Okay. So we can we can do X-ray, CT, but if the patient is in advanced diseases, if no prognosis is very bad, and the patient is in the terminal stage, you should not do any investigations because did not get any benefit to the patient and it did not going to alter the line of management of that patient. So you have to uh, uh, think twice before doing investigations when the patient is in advanced cancer or non-cancer advanced disease with the breathlessness. So communication, that is very, very, very important in breathlessness, the communication part, because initially I told that it is little bit different. The management of the breathlessness is little bit different from the normal setting than the palliative care. So here the communication part is very, very important. Otherwise, it will get more harm to the healthcare professionals because I already told that the investigations. So active management of breathlessness is not benefit to the palliative care patients. So that is you have why we are not doing any investigation, why we are not proceeding too much intervention for this patient. That is you have to communicate to the patient if possible or caregivers earlier. That is very, very important. Usually we are telling that the palliative care is starting at the time of diagnosis. So for the COPD or interstitial lung disease like patients with the non-cancer patients, usually when you get the patient in the initial stages of disease, you have to start communication earlier for the upcoming or expecting anticipatory complications and prognosis of the disease. So you have to address both patient and caregiver. You have to talk with the patient and you have to identify what are the real issues they are facing and what is the distressing symptoms for the caregivers also. Explain about his or her condition. You have to explain the caregiver or patient what is the current situation of this patient, what is the prognosis of this disease, what is the underlying etiology. So what are the inconveniences and risks of investigations they are while we are doing this time. So what are the benefits of treatment? What is the life expectancy of the patient? So these are the things you have to communicate earlier to the patient if possible or to the caregiver. If it is happening earlier, it is very, very easy to manage these patients when they are coming to you with the end of lifetime or maybe with the terminal breathlessness. So this is very, very important. You have to communicate to the family members why we are not doing this investigation, what are the benefits of this treatment, what are the life expectancy, what are the risks for these patients, what are the prognosis of this disease. This is you have to communicate to the patient if possible or with the caregivers. That is very, very important. If they know, if the caregivers or patient knows why we are not doing, then they do not blame us. Otherwise, they will blame us. Why the doctor is not giving oxygen? Why the patient, why they are not doing any investigation? Why they are not doing any X-rays? So these are the so many questions we are facing when we are treating these breathlessness patients during the end of life. So when we are giving a proper communication, it will benefit to us. ICU. Is any need to shift the patient to ICU when the patient is in terminal breathlessness or in the advanced lung disease patient with breathlessness? Is there any need? What is your opinion? Any opinions?
It is according to the patient attenders view, it may be differs.
Okay. So what is the condition of the patient when they are presenting to you? That is very important. It's initial stages of breathlessness or maybe in that is then another entity. But when the patient is coming with breathlessness in an advanced lung cancer disease or in an advanced disease conditions like COPD or interstitial lung disease patient, there is no pointing to shift the patient, no point in shifting the patient to ICU. It is get more and more suffering to the patient because the prognosis and the life expectancy is we know. So there is no curative treatment for that disease. Only symptom management or only palliative palliation of the symptoms. So that is, you have to communicate to the caregivers, and if they are willing, please do not shift the patient to ICU. Okay, it's very, very important. But we can give a good symptom relief for the patient without shifting the patient to ICU in palliative care. So in the coming slides, we are discussing how we can manage. So management. How we can management. So initially I told that if any correctable cause is there, if any correctable cause for the breathlessness, you have to identify it and correct it. And we can consider some non-pharmacological measures to treat the breathlessness and also some pharmacological methods. So these are the some correctable causes. If the patient is on COPD and asthma, we can consider some bronchodilators and steroids. If any evidence of respiratory infections, we can give antibacterials, antibiotics we can prescribe. And the pleural effusion, we can give pleural effusion. That is pleural tapping, that's thoracocentesis. Ascites. Ascites is the fluid in the abdominal cavity. That is paracentesis we can do, or we can consider some oral diuretics. Anemia, if the patients with anemia also presenting you with breathlessness, that time you find that if the patient has symptoms of features of anemia, you have to give blood transfusion to correct anemia. And the patient, the non-cancer causes of breathlessness like heart failure, you have to give some diuretics, ACE inhibitors. So that is also very important. So these are the some correctable causes. What are the non-pharmacological measures? So this is very, very important as for a palliative care nurse. The non-pharmacological measures is very, very important because you are the first one who see the patients with severe breathlessness when the patient is coming to our OP or maybe to the IPD or in the casualty. So if you are seeing this patient with severe breathlessness in advanced cancer or advanced disease, your calm presence of healthcare team conveying empathy will relieve the anxiety. So the patient has severe anxiety because of fear of death. So your calm presence and empathy will relieve it. When the anxiety will decreases, breathlessness also decreases. I already tell that dyspnea anxiety cycle. When the anxiety increases, breathlessness increases. So we can reduce, when we can reduce the anxiety, it will reduce the dyspnea also. Comfortable position. Most of the time, the patient is more comfortable in the propped up position. And you have to loosening the tight clothes. If the patient is wearing tight clothes, you have to loosening the clothes. And handheld fan. It is not 100% benefit to the patient. Sometimes it may work. So you can use an handheld fan in front of the patient's face. It will improve the circulation and reduces the breathlessness. And we can open the doors and windows. That will increases the perception of space, and that itself decreases the breathing. So these are the non-pharmacological measures you have to consider for the initial management of breathlessness. When these non-pharmacological measures are failed, we can go in for pharmacological measures. What are the pharmacological management? So we can give some bronchodilators, that is short-acting bronchodilators, long-acting bronchodilators with or without O2. Steroids. We can give injection dexamethasone. You can consider a higher dose. The mechanism is it will reduces the peritumoral edema and airway edema. That itself decreases the breathlessness. This is the mechanism why we are giving steroids for the breathlessness. And we can give nebulizations also. If any evidence of infection is there, we can give antibiotics. So this is the another important drug. This is a morphine. It is a wonder drug for breathlessness. If anybody knows what is the role of morphine in breathlessness management? Anybody has any experience?
No, ma'am.
No experience. Okay. Anybody heard about this morphine can use in for the breathlessness? Anybody? So this is the first time you are hearing that the morphine is using for breathlessness. I think you are not aware about the morphine for the breathlessness part. Okay, we will discuss. So also oxygen therapy, NIV, anxiolytics. So these are the management for the breathlessness. But in the coming slides, we will discuss in detail each about the morphine, oxygen, anxiolytics, everything. So morphine. How morphine can use for breathlessness? Usually we know that morphine is a narcotic medicine. It is opioid. It's a strong opioid and it is mainly using for the analgesia or for the pain, for the severe pain. But it has some role in the management of breathlessness because the low dose of opioids is very safe and effective for the management of breathlessness. This is a wonder drug. It is usually used for the intractable dyspneas. It is not responding to any other treatment. When the patient is in the end of life or in the terminal disease or in the terminal stage, the breathlessness is not able to treat with any other medicines, we can try morphine. It is for the intractable dyspnea. The mechanism of morphine in breathlessness management is the sensation of breathlessness will reduce. It will reduce the sensation of breathlessness. And usually the morphine will act on the respiratory center and it will reduce the respiratory rate. The morphine did not given 100% symptom relief, but it will reduce the what difficult or the decreases the respiratory rate and effort of the patient to get a good breath. So that is the action. So it acts on the respiratory center and it will reduce the respiratory rate. And it also reduces the inappropriate and excessive respiratory drive and reduces the work of breathing and reduces the anxiety also. So usually for the pain, usually we are giving as a 5 mg as 4th hourly, 6th hourly or 8th hourly. But the low dose is prescribing for the management of breathlessness. So morphine 2.5 milligram given as an 6th hourly or 8th hourly, that is depending upon the patient's symptoms, we can start. So before starting this morphine, you can tell the patient or to the caregivers that this is mainly for the breathlessness, not for the pain. Okay, because if you are dealing with a advanced cancer patient, this is not get any problem from the caregivers or from other family members. When it is using for the non-cancer conditions like COPD or interstitial lung disease, if you are starting this morphine, most of the time after the next review, they will stop the medicine after few days. If we are asking why you are stopping this medicine, then they tell that our neighbors told that this is medicine is mainly for the cancer. So I have no cancer, doctor. That's why I am stopped it. So if you are giving it for the breathlessness, you have to explain why it is giving. It is mainly for the breathlessness. What is the mechanism? How it will decrease our breathing? That you have to educate the caregiver. If possible, you have to tell to the patient also. Okay. Next important thing is oxygen. Is it really helpful? Oxygen for the terminally ill or end of life patients with advanced disease? Any suggestions or any opinion? Any idea? No idea. Okay. So usually we are not completely avoiding the oxygen. Here usually we are giving an oxygen trial. Usually giving oxygen trial for 10 minutes. Why it is for 10 minutes means the oxygen and the blood equilibrium will take a 10 minutes to minutes. Then if the patient is getting any benefit from this oxygen, it will get it within the 10 minutes of starting oxygen. If the patient is better with this oxygen, we will continue it. Otherwise, we will stop it. Okay. So most of the time, cancer-related breathlessness, the too much mass. The most of the tumor cells are occupying the lung tissue. This is the cause for this breathlessness, not only the hypoxia or low oxygen level. When we are giving too much oxygen, but there is no space or no area to get hold the lung to get a good oxygen, there is no point in keeping to continue this oxygen therapy. So you have to give a proper communication and documentation before giving this O2 trial, and you have to explore the insight of the caregivers and patients regarding some misunderstandings about this oxygen therapy. So the malignancy is that filling the lung, that is the main cause of breathlessness in these patients. So that you have to communicate. Usually the COPD patients, the baseline oxygen is low. Usually more than 89 percentage in room air is sufficient for the COPD patients. When we are giving more oxygen, it will result in carbon dioxide retention and the patient become more and more drowsy. So if you are giving this out to trial, the patient is getting good benefit, then we will continue the oxygen therapy. So from when we are giving this oxygen therapy, it can given through an nasal cannula or made through the face mask. So which the nasal cannula is more preferred. Why? Means if we are using face mask, it will dry up the airways and the patient has feeling of sense of suffocation and the difficulty in communication. The patient is not able to communicate properly because of this face mask. So if you are giving oxygen, the nasal cannula is the best option than face mask. So benzodiazepines. Benzodiazepines, I already told that the anxiety has a very important role increasing the breathlessness. So to relieve this anxiety, we can consider benzodiazepines. So they are not the first line agents, but we can give a lorazepam or short acting like midazolam. Usually we are commonly giving midazolam. If the patient has terminal breathlessness, it is very difficult to manage. So for during that terminal breathlessness stage, we can give a morphine as a continuous infusions along with benzodiazepines like midazolam. If the patient is not able to responding to this, we can consider palliative sedation. So continuous infusions of morphine, benzodiazepines like midazolam. If need, the patient is also giving haloperidol infusion also, antipsychotics. So these are the management of terminal breathlessness. So from the nutshell of this breathlessness management, it is mainly focused on the quality of life of the patient. So integrate the palliative care from the beginning of the diagnosis of the patient. Need to slowly sensitize about the prognosis. So if the patient is integrate the palliative care from the beginning, you have to slowly sensitize or giving hints or clues or ideas to the patient and caregivers regarding the prognosis. Aggressive management like ICU admissions, intubations, ventilator, tracheostomy is not advisable for terminally ill patients. This is a better version of yourself, and usually when you have to give a proper communication, everything is good, it become more ethical and stress-free period of management of breathlessness when we are dealing in a terminally ill patients or in advanced cancer or advanced disease patients with breathlessness. This is the nutshell of the breathlessness management. Is there any doubts till now? You can ask. So it is a little bit difficult to understand the concept of this management of breathlessness with morphine, without oxygen, and with the benzodiazepines. So, but we have patients, they are coming with oxygen support. After starting this morphine, they can wean off the oxygen and they will go to home without any oxygen support. So such a wonder drug is morphine. So this is not for 100% of patients, but it will do wonders for some of the patients with breathlessness, with advanced disease. It's mainly for the intractable disease. Any doubts? Any clarifications? Anything you can ask. One question is it okay to keep COPD patient always on oxygen therapy? We are focusing to the patient symptoms. So usually in our hospitals, they are more focusing to the pulse oximetry. They are when the patient is suddenly the patient has symptoms of breathlessness. First, we are checking the pulse oximetry, and when while we are checking the pulse oximetry, most of the time the SpO2 is very low. So when these symptoms started, we just what started on oxygen therapy. When the patient is symptomatically better without seeing this SpO2, most of the time the patient become better, but the SpO2 is still low. So usually we are more focusing to the patient side, patient symptoms and their response. So there is no point in continuing this oxygen for the COPD patients. When the patient is more comfortable with oxygen, we can continue it. Otherwise, we have to stop it. And we can start morphines for this advanced COPD patients. It will do wonders for that patient. Low dose morphine is very, very important. Okay, okay. Anyway, we will share the slides. So I think there is no more doubts. Then we will proceed with the next topic, that is cough. So little bit about cough. The tumors are more likely to cause cough with involvement of airways than the lung parenchyma. So this is the another entity like breathlessness. The patient with cancer or advanced lung conditions may presenting you with the chronic cough. Cancer involvement of the pleura, pericardium, mediastinum, pulmonary, lymphatics, blood vessels, they may cause cough. So these are the some causes of cough in advanced cancer conditions. Other thing is aspiration. Usually they will present with the cough on feeding. Most of the time the caregiver tell that the patient is not able to take any feeds like liquid, semi-solid or solid. When they are trying to give this liquids, the patient has cough. So this is high chance of aspiration that will result in aspiration pneumonitis or pneumonia. So the conditions with hypersecretion of mucus are also associated with the cough. Cough, if the patient has a chronic cough or severe cough, that will cause some physical complications, including chest wall pain, rib fractures, urinary incontinence, sweating, exhaustions, sleep disturbances. These are also very, very important because when we are dealing in chronic cough, we are just focusing to the cough symptom only. But because of this cough symptom, the patient is more suffering with these complications. Sometimes chest wall pain, rib fractures, urinary incontinence. That is very, very common symptom. Usually we are getting when patients with chronic cough. Sleep disturbances. That is also very common. Sweating, exhaustion. So these are the important things you have to know when the patient is came to you with a chronic cough. Treatment for the cancer related causes. When we can consider some radiotherapies, chemotherapy treatment may palliate the cough due to tumor. If the cough is due to tumors, we can consider some radiation or chemotherapies. And we can use steroids. The mechanism of steroid is same for all type of cancer related things. That is, it will reduces the peritumoral edema, and also when this airway edema will decreases, it will reduces the obstruction, airway obstruction. That itself relieve the symptoms. If any correctable cause is there, if any underlying infection or anything is there, you have to correct it with the antibiotics. And we can give some use some centrally acting antitussives, and rarely we can use low dose morphine. That is also very important. That is same effect like breathlessness. We can use low dose morphine for chronic cough due to cancer related issues. And we can give hydrocodone or codeine or dextromethorphan. That is the different types of cough syrups. So these are the main things usually we are seeing in patients with breathlessness and cough. If you have any doubts, you can ask. Any doubts? No doubts.
Some few messages are here.
It's messages is there. Okay, okay. I will
Is it
check.
okay to keep
Okay.
COPD patient always on oxygen therapy?
That is I already given, ma'am.
Ma'am, there is one
Okay.
question.
What
The
is
cause
cause
of
of dry cough?
So what cause dry cough? There are usually we are telling that this expectorant cough of and cough and also dry cough. Usually the dry cough is here we are more dealing with the tumor related cough. That is maybe involvement of the pleura or maybe involvement of the pericardium or that are the tumor related coughs. So that time you have to give this antitussives or what this expectorants or the usually we are giving dry cough that is syrup Alex. So these medicines are not working. So that time we can consider uh, what morphine or maybe low dose morphine is very important. Otherwise, if any infection is there, we can give antibiotics. So there are so many causes for dry cough, but here we are more dealing with the cough related to the cancer. Anything else?
No, ma'am.
No. So
think
anyway,
there
Hannah
is
will share the
doubts.
slides. So you have to go through the slides after the session and that non-pharmacological measures is very important. That cycle, that breathing, thinking, functioning cycle is very important. What are the management? How this morphine will act for this breathlessness management? What are the real issues when we are dealing with the patients? That's apart from the physical symptoms, other real issues. So these are the very, very important things and how we can manage that is without shifting the patient to ICU, without giving unbenefit oxygen to the patients with the terminally ill patients. So these are the important things you have to keep in your mind.
Dear participants, please ask your doubts. Ma'am is with us. I think we can wind up today.
Yeah.
Thank you, ma'am. Thank you for your insightful session.
Thank you, ma'am.
Thank you, ma'am. Thank you so much.
And
Thank
please share
you.
the PPT with me. So that,
Thank you.
okay. So, dear participants, thank you for participating and we can wrap it up for today.
Okay, bye.
Bye, ma'am.
Bye. Bye.